There is a lot of bench of methods, advanced diffusion methods, which I will not go over, but all the time they are evolving and new methods are coming. When we are talking about multiple compartment models and fiber reconstruction algorithm and different to better understand and characterize those voxels with corptosis imaging and QBEL, and there is many methods based on different algorithm, based on different assumption of the way that the diffusion is occurring within the voxels. And if you are interested, there's really a lot of methods. So what are, yes, okay.
Going back to stroke and DTI, still today in a clinical setup, if in the ER there is a patient with a suspected stroke, he will be sent to do a CT scan. So
why?
Yeah.
The question was is if MRI is great for stroke, why a patient is coming to the emergency room. Rarely will get an MRI, beside our Prime Minister. But the reason is there are in US and other places in the world what they called stroke centers. And when you have stroke centers, people will get the MRI. It's the length of when somebody's coming, MRI is 40 minutes. So if somebody's coming in the middle of the night, there is no emergency in MRI. There is no place to put them. Really, question of money, okay? Let's be honest. And I don't know what you heard in the lecture, but for many, it's important to do MRI if it will change your treatment. So now, those days, the only therapy exists, TPA. You need to know if it's a bleeding or ischemic. CT is enough, okay? So you do need it if you have new therapeutic. But just currently, for just to know if it's ischemic or bleeding, CT is enough. There are some potential, and we do research or specific other methods, so we do have those studies for stroke, acute stroke. But it's not something that really must be done if you don't have therapy now. Okay? So what are the clinical applications of all these diffusion-based, and I put this as a package. So when we have diffusion axonal injury, we want to know this, and a lot of studies in US, those play football with so a lot of axonal injury. We want to know about neurodegenerative disease and demyelination disorders. So you heard about MS. I'll show you some examples for pro-surgical mapping, for neurosurgery. When we're talking about brain development and developmental disorders, we want to know if there is specific. We have a child that doesn't walk at the age of 2.5. If he has cerebral palsy, we want sometimes to know if it's only this network or there are others, some maybe a lesion that we can interfere. Diagnosis and assessment of severity of the injury. And of course, if we are talking about neuroplasticity, understanding changes in structural connectivity are very important. So there's a lot of application in this method for understanding glaucoma. So we can see really the optic nerve and see differences in its maturation, blindness, multiple sclerosis, Alzheimer's disease, and a lot of applications. So just a few examples. One that is routinely done in our center for between 5 to 8 patients a week is what we call pro-surgical mapping. Because when somebody has a lesion or tumor in his brain and he's a candidate for resection, we do want to know that it doesn't, when he's to avoid neurological deficits. So many years ago, we were just mapping those function area. If the lesion is near motor area, we'll map the motor area and we'll send it to the navigation, to the operating room. And then the neurosurgeon will know first the amount of resection. Because what you see here, a nice lesion in the image, when he opened the brain, it doesn't look very nice. It doesn't look, sometimes it's just the blood and red tissue. So it doesn't distinguish so nicely. And if there is here or around the lesion specific function area, we do want the neurosurgeon to avoid cutting it. So especially in malignant tumor, they don't just cut the tumor, they really cut some about 2 centimeters around it, because we know there are infiltrative cells. So the amount of resection or the size of resection is really decided preoperative, but the vicinity to function area. But we know that it's not only function area, but it's also connection, because if I'll cut the fiber, even if I won't touch those neurons that are responsible for our function, we do get neurological deficits. So currently we provide to the neurosurgeon information regarding functional area from fMRI and structural major fibers. For example, you can see here a tumor, and we can see here the corticospinal tract, because we don't want severe neurological deficits. We don't want him to come and won't be able to walk or won't be able to talk or blind. So this major function or major network, in this case, we map, and all this information is going down to the operating room. Neurosurgery now, most surgeries are performed with navigation system, meaning when we have this MRI preoperative, it's going to the operating room, it's fixed, and now when the surgeon is pointing with the laser to a specific point within the brain, he can see it in the image, how close he is to the functional area, how close he is to the structure, to the network that are in the vicinity of the lesion, and then he knows the amount of resection. And there's a lot of studies going on research to validate, because I can map a network, I can say, okay, this is a cortical spinal tract, whether it's true. So there's a lot of research going on with intraoperative mapping. They give stimulation, and we can learn both on networks and function. So this is something that is routinely done in many centers now, what we call preoperative, pre-surgical mapping, both for fMRI and for DTI. Other applications on brain development. And in brain development, just because there are so many changes, like I said, during the first year, so cells become more myelinated. So especially in synapses, the extracellular space become more restricted. So if we are now looking at an 11 years old child on his fractional anisotropy map relative to 11 years old child, now you can see there is a big differences. And if you can remember when we talked before the images that a 2 years old child has the same contrast as a 22 years old, now when we use diffusion, we can see major differences. And we even took it further and push it more. And this was the work done with Yaniv and me many years ago, that we really develop a high B value, another method which is more sensitive to this restricted diffusion. And now if you look at a child who is 2 years and a child who is 7 years, you can see by eye a big difference, and also during. And we can quantify it. So we can learn now how changes are during development, and to make this quantitative measure. And once we have this normal development, and now you see that at the age of 2, it doesn't become plateau, it's really continue to change. And now we can learn developmental disorders. And the first application that we did was on young children with autism, that what we see that in a specific brain region, the brain seemingly looks like it's more mature, meaning like it was beginning for like extra maturation. We have different hypotheses now, and a lot of studies now replicate these findings, that something in the course of development of autism is different. Maybe there is a lot of abnormal pruning. We born with an almost fixed amount of nerves, of cells, and then there is a normal pruning during the first few months of age, and probably in autism this is a abnormal. And there's a lot of debate and a lot of studies in NIH now in US that they take sibling of autism, and they do want to see them in the early, even from early age, from age of 0 really, to see them, hypothesize that some of them will develop autism, and then they can see what's change occurring for early diagnosis of autism. But this, once we have sensitivity for normal development, we can take it for abnormal. And just to let you know that this is done also on fetal MRI. So more on the research, but many sites. And now we're trying to understand what's going on in the brain of fetal. And this is just an example that already in the fetal stage, we can see major fibers. We can see the corpus callosum, we can see corticospinal tract, and we try to understand all these things already at the fetal stage. Other application that are currently is on preterm and term, and this is just, the movie is showing just the way we scan now preterms up to age of 1 month without any sedation, just feeding and let them sleep. And there's a lot of question and a lot of things that are crucial for clinical diagnosis. For one example is when we talk about prematurity, and we know that prematurity by itself is a risk factor for a lot of neurological development. So if we have premature, how do we know the prognosis? And this is something that is a daily question by the radiologists and neonatology. They have a family that the child was born at the age of 24. What is his prognosis? He can become cerebral palsy. He can be almost normal, just have maybe ADHD, some dyslexia, but normal child. How do we know the condition or the situation or characterize the brain and understand the prognosis of this child? And this is something that we push all the time, research really to help physician give answers. And like I said, the main question here is prognosis. There's a lot of new therapy. A lot of children that are born with hypoxic ischemic, they put them now what we call hypothermia. They put them in a place in a cold place because then they slow down the metabolism. How do we know if it helps? How do we know to whom it helps? So the gap or the border between research and clinical is very delicate because once we develop something, it's really immediately translate in the clinic. Other studies now look at maturation of networks. So this is a nice study that they try to see from age 12 to age 20 changes in network and then to compare and to see differences. So once again, if we will establish this normal, we will be able to say what is abnormal. Maybe even now there is a theory about schizophrenia that is a developmental disorders that manifested only later in years. Maybe if we know and have these norms, we can study and understand other things that maybe we don't even, or just hypothesize that they are developmental disorders. And this is something that we do on Parkinson together with Nir Giladi that gave you a lecture on Parkinson. I don't believe he ever seen these results even. So we take those patients that he told you, or subjects that are carrier of mutation of LRRK2, which are in high risk to develop Parkinson disease. And Parkinson probably evolved during many years until it became clinically diagnosed, because diagnosis is clinically after about 80% of the neuron already dead. So once we diagnose, the disease is already in a very advanced stage. So we do want to have this early diagnosis, especially for those that we know are genetic carriers. So what we took is a group of non-carriers, carrier, and we did find a specific area that are differences. We did another study with the dopamine receptor with that SPECT imaging, and we have initial results because they have a longitudinal studies. We know that if we do take those carriers and said, okay, they are different from healthy, their brain looks more like Parkinson disease, and after 2-3 years they converge and become Parkinson, then we can go back and say, okay, this was early diagnosis. And currently we have 2 converters that we retrospect could identify that they will develop the disease. So pushing all research is really for clinical needs, daily clinical needs. And the last bench of method that I want to focus is on vascular imaging. And actually my main research focus on the vascular system, so you'll hear a lot about it. And And when we are talking about vascular system, because you can look at the brain and say, okay, there are nerves that must function. There are people who said, okay, there are only glia and nerve cells. And we said, okay, but everything needs this vascular system, because if there is any abnormality in the vascular system, brain won't function. And vice versa. When the brain doesn't function well, secondary, we do see impairment in the vascular system. So it's many disorders now, like in any disorders, we can correlate or relate also to abnormality in the vascular system. So we have many methods, and I said MRI is multiparametrics. There is a lot of methods and different aims. If we want to look at brain function, we look at the fMRI methods. If we want to talk about structural connectivity, we'll go to the diffusion-based methods. And as you saw, there are many methods. If we want to talk about structure, there is a lot of contrast in the structure. And when we talk about vascular imaging, there are methods to look at large blood vessels, like those that you can really see, the MCA, you can really see large blood vessel, and in this method also quantify the flow within a specific large blood vessels. But if you want to talk about tissue perfusion, we don't want to image the blood vessels, but to understand what the change, how much oxygen is transmitted to the tissue. Then we're talking about tissue perfusion. So there are methods like DSC and DCE that we do inject contrast agent, and then we see the dynamic of the contrast agent within the tissue, and then we can learn, and I will go soon, on various parameters of the vascular system. And there is another method that is called, also it's a family of methods that call arterial spin labeling, which does not require contrast agent injection. And the benefit is we can do it to fetal, we can do it to women to people who are, has any allergy to gadolinium or has any contradiction to gadolinium, like if a woman is pregnant, we don't inject, or if somebody is coming. So this is really a method that become, I think just during the last few years, it's really become a basic method within the clinical setup. A lot of problem, it's not a quantify and knows a lot of the problem that exists with this method, but if I would have given this lecture 5 years ago, I would say this is only research. Now it's kind of the package within the clinical setup. So what do we look when, or what do we want to look when you look at the vascular system? First, we want to look at the blood volume. We want to know how many blood vessels within an area. So we can get this information from different methods, DSC, DC, doesn't matter. So we can call it cerebral blood volume or volume of the plasma, which is just relating to the hematocrit of the blood. But this gives us information how density the blood vessels within an area. Of course, gray matter will be more rich in blood volume than white matter. And if I have a malignant tumor, which is very vascular, I'll get increase in blood volume, and then I know it's a malignant tumor. I can get some temporal information about how fast the blood is going within how fast it's coming to a specific area within the brain, what we call mean transit time or bolus arrival time, and then I can quantify it by time. And if there is any disease, like I'll show you later in specific pathology, that there is a delay in the arrival of the blood, then I know and can diagnose. I can talk about flow. If I have patients with carotid stenosis, I want to know how reduced the flow is. And the last thing is, again, during the last 2 years has been implemented also in clinical, because the vendors of the MRI provided also a software to analyze this, is what we call permeability imaging. Because till now we just injected a contrast agent, and if the tissue was becoming bright, then we said, okay, there is impaired blood-brain barrier. But we don't want to know it's binary, yes or no. We want to know how much. And now we have a lot of pharmacokinetic models. We inject, we get dynamic images, and then we can quantify various parameters, doesn't matter, K-trans, KF, that really quantify this impaired permeability. And even, for example, Alzheimer, we know that there are specific areas within the brain that have very, very slight permeability problem or impaired permeability. And a lot of things, because once there is impaired permeability, a lot of toxins that are within the blood can enter the tissue. So there's a lot of study now they're trying to understand, for example, in lupus, we're now investigating whether impermeability with a specific nuclei enable transfer of toxin to the tissue, and this is really part of the disease. On the converse, we know that the BBB block compound to go out. That's why chemotherapy in the brain is not very efficient. So there's a lot of companies now that they try to open this BBB locally within the tumor, and then I can infuse drug, and if I local the BBB locally, then the drug can enter the tissue and help. So there is a lot of, once we understand what's going on, we learn how to measure it, then we can use it for our purpose. So what are application of those methods? Brain aneurysm. Aneurysm and animal formation. You heard a lot, I think, lately on aneurysm, Arik Einstein with aneurysm, not in the brain, but once they are bleeding, it's very dangerous. So if we have any aneurysm, which is just a small bulb and very thick of the blood vessel, it can bleed anytime, we don't know, and then we can lose the subject. So we want to monitor this aneurysm. We want to know that if we did any treatment, if we did put any stent, we want to know that it's helping. So a lot of study, a lot of use of those methods in monitoring, diagnosis, trying to assess what the prognosis of this aneurysm. If this aneurysm is stable, we don't want to touch it. How do we know if it's going to bleed? How do you know how it's changed over time? So this is one very important question on this field. Of course, if we have any stenosis, any occlusion of blood vessels, we want to know the location. If it's in a stroke, if it's an acute phase, if we want to do an intervention, of course, we need to know where we need this intervention. Angiogenesis is a very important process, especially in brain tumors. So we want to know, indirectly monitor angiogenesis. Also now there's a lot of talk, okay, if we know there is angiogenesis, maybe we can create it on purpose on area after stroke. And maybe if we know that there is area with angiogenesis, maybe if we develop stem cell therapy for stroke, we'll know where it goes. So there's a lot of, once we understand and can improve diagnosis, then we can use it to improve therapy. And a lot of study also for brain flow, if you want to see any changes in just stenosis or cortical stenosis or carotid stenosis or any stenosis within the brain. So there is a lot of application, and all those patients, a lot of these vascular methods are part of a return protocol. As I said, each patient is coming, and once we know the question, he has a specific protocol. Those vascular methods, and I just monitoring those parameters using one of the methods I mentioned, are applied to stroke, to vascular disorder. If we have patient with carotid stenosis, aneurysm, brain tumor, pre-surgical mapping, again, I'll talk if we suspect any bleeding, hypoxic ischemic, and I'll show you some, and a lot of research on neurovascular coupling. And I'll emphasize on this because when we're talking about fMRI, actually we don't really monitor neuronal activity. What we monitor is hemodynamic response. And unfortunately, many people forget it. So we have a patient stroke. He has a problem with his vascular system. And then we said, okay, the bold contrast doesn't respond, meaning there is no activation, meaning there is no hemodynamic response. Maybe we do need other models. Epilepsy. We know that many of this coupling between the neuro and the vascular is abnormal. So maybe once we prove this understanding, a lot of the fMRI methods and results will improve. So there's a lot of research on this field as well. So just a few examples of the use of vascular methods in routine. One is brain tumors. And when we are talking about brain tumors, there are really clinical criteria for diagnosis malignant tumors. So if this is a patient, I think it was 42 years old, he's coming with what we call non-enhancing lesion. You see, this is after gadolinium, it's very slight enhancing black lesion. We see tumor, we see lesion, but since it's not enhancing, everybody assumed, and he was coming with what we call low-grade glioma, meaning it's a benign tumor. But when we do perfusion, you can see that the cerebral blood volume is very, very big, When we measure a ratio, we got a ratio of 5, above 5. Clinical criteria, if it's above 175, it's high-grade tumor. And after biopsy, after surgery, it was glioblastoma, meaning the very malignant tumor. So why this tumor wasn't enhanced? Maybe if we would scan him 5 days later, it would enhance. Why? Because blood-brain barrier was intact. It was still okay. So that's why it was not enhanced. So there is a lot of dynamic process in brain tumors that we need. And also it was supported with MRS. So really when we saw those images, it's not low-grade glioma, and biopsy was, as I said, confirmed it's a glioblastoma. And another thing I said, we want to be able to monitor angiogenesis. Why? Because angiogenesis indicating malignant tumor. Because if we have blood vessels that are highly vascular, we know that for radiation it's good, because radiation will interact with the oxidative tissue. So if a tumor is very oxidative and we have a lot of blood vessels, it will respond better to the radiation. So this is just a method that we tried really, and this is the same patient that you can see really a ring of enhancement, and we could detect indirectly, and this again was confirmed with biopsy, that we can now see angiogenesis indirectly, is increasing the blood volume. And this is something that really sits, in this case, in clinical practice. This is a basic paper that really radiologists work with. Like if you have any intraaxial tumor, if you have a lesion and you want to know what you're doing, use conventional imaging, contrast agent. If it's enhanced, yes or no. If it's not enhanced, and it's really used, it's actually, without this paper, this is the way they think. And they do use perfusion, and they do use, not always, but often, hopefully often, MR spectroscopy, and then they build a diagnosis. So clinical use of this method, and again, it's multiparametric. It's never one method. You have to build it smartly, like a puzzle. Other application, like you see in stroke, again, in T2, we cannot see hardly anything during the acute state, but if we do look at delay, if we do look at MTT, cerebral blood flow reduced, cerebral blood volume shouldn't change if there is no total occlusion of the blood vessels. So this is again the use of flow or perfusion in stroke imaging. Another thing, it's guided biopsy, because if the patient is not going for total tumor resection but just for biopsy, we want to make sure that the biopsy is taken from the most malignant area within the brain. So what we can do is mark for the surgeon within the tumor 2 areas, one which is hyperperfused, one which is hypoperfused or even normal perfused. Take the most hyperperfused area and then diagnose the lesion. Because especially for biopsy guided, it's important to know where we take these samples from. So this also information that can be transferred to the operating room. Last application I want to show you is on moya moya, and moya moya it's a Japanese word meaning puff of smoke. I hope this is the true letters, I just found it. And in this is a disease that children are born, and there's a lot of occlusion mostly on large blood vessels, on MCA, middle cerebral arteries, and because it's slowly progressive, and it's not like a stroke that's blocked, and it's slowly progressive, they have a lot of collaterals from different directions, and that's why when they do angio, it looks like a puff of smoke. But many often they do get strokes because those are very narrow blood vessels. So during time, because it's a blood vessel disorders or disease, and the blood vessels are affected all the time, so they can get a lot of stroke, and there is always a question of surgery. So what's being done clinically, they do look at dynamic. I said at the beginning, one important thing in MRI is looking dynamic process. So they do inject gadolinium, they do look dynamically. Again, just visually. They assess how long does it take, because for collateral, circulation until the gadolinium is reached, it's very slowly. It's delayed in time. Again, they don't quantify things. What we try to do, this is the one part of the PhD of Oren, is really to quantify this and give values, to know what's happened in time for the gadolinium to arrive, to know what's happened before and after surgery. So all these are clinical needs because they sit and they need to know this child should go to surgery for collaterals or not. So on those crossroads of clinical decision, that's where research is really trying to help. And if we have a lot of parameters, as I said, radiologist sits and try to combine all this information in his brain and give the diagnosis. But if you want to do it on the voxel basis, then we do need a lot of statistical and computational tools. And there is a lot of tools and a lot of approach, and of course I'm not going to use, but having this algorithm and those approach really can improve our diagnosis and provide even a voxel base, because a lot of tumor are heterogeneous. So there's no meaning to say this tumor has high vascularity. If I want to see small changes, I might need to look at the base of the voxel basis. I might need to look at the histogram analysis. And this is a lot of approach how we take, and not just us, but really on the world, how to segment and classify tissue. Because if you have an area like this, which is bright on a specific sequence, it can be just edema, just water, or it can be tumor, infiltrative tumor. By one method alone, we cannot say. Radiologists, based on conventional imaging, cannot say. If we do understand that infiltrative tumor will changes in the cells compartment, meaning diffusion will give us information. And if we understand that for malignant tumor, they need angiogenesis, meaning cerebral blood volume will increase. And if we know that then oxygen extraction fraction will change, then we build the protocol, get all this information, we can have 5, 10, or 20 parameters for a voxel. Then we need all this computational method, any algorithm, supervised, unsupervised, doesn't matter the approach, to enable. And this is the approach of the computer-aided diagnosis tool, that we get all the information, hopefully give the radiologist something that not just the volume is changing, but listen, malignancy is changing. And this is just one effort that we are trying to do, and is really to get the radiologist all the information, because like this is enhancing area. But if a patient receives radiation, this can be response to radiation, meaning it's just what we call pseudo-progression. It's just a reaction for the radiation, but the cells, that the tumor actually respond. Or it can be that the tumor didn't respond, and this is a progressive disease. Just by conventional imaging, radiology cannot diagnose this. And this is one, if you ask neuro-oncology always, how can I differentiate between radiation necrosis and progressive disease? And just by combining a lot of information and having really software that integrate all parameters and use specific and more complex and sophisticated algorithm, we can answer this once we have hypothesis to what's going on microstructural. Because we need to combine what we see in imaging, what's going on in the tissue. So just to summarize the things, MRI is not a standalone. It's always within the context of clinical and imaging parameters. Nobody will say, okay, just do MRS and give me the diagnosis. If I don't know why he's referred to, if I don't have other information that may help, if it's EEG, if it's clinical, if it's a pathology, it's always just a big, huge puzzle of a lot of methods that I really need to understand. There's a lot of trend now of doing radiomics, meaning combining the imaging with what we know from genetics. So if I have a tumors, and all the approach now is not just like for brain tumors saying glioma. Glioma meaning they're coming from glial cells. Now there is a trend not to call them glioma. It depends on the mutation that they have, because two patients with the same what we call glioma, the same grading of glioma, will have different prognosis. Why? Because actually, just like having both two people have headache, One didn't drink water, the other is brain tumor. So it can be the same prognosis. So we really want indirectly detect these things, but we really need to understand all the context around us. Just take home message, even if you just forget and didn't understand whatever I said. MRI is multiparametric. It's not just one method, and it's evolved all the time. And every year, every conference that we go, new methods arrive. New methods that are currently under research in 2 years will be in every machine, in an MRI machine. This MR multiparametrics is not just acquisition, a lot of development in analysis. So we have something, we want to analyze it more reliable. We need gold standard. We always need to compare it with other, with histology, with clinical outcome, with genetic, with samples, whatever. We really need in clinical research, we need always two things. We need to translate to the individual subject, and we need to have a validation to other study. Regarding you, there is a huge gap between what can be done and what is actually used in clinical setting, and I'm really not happy to say this, but we can do a lot and very few is done. Mainly money, manpower, time, things that are maybe done in private clinics, just because if a radiologist has 5 minutes to read images, he won't sit and do all the analysis. As much as things are progress, time of running the system and analyzing the data become more complex. And building this protocol is what we need to know. Is like we have a specific and tailored protocol. We need to know what the clinical question, what the problem, and then to tailor the right protocol. Because we have a huge amount of data, and radiology data, we're talking about megatera of data. It's a huge amount of data. We need, and if we want to analyze things, a lot of things are supported by a CAD system. So we do want, like you said, to help radiologists. So they have something, immediately will transfer, come back, and they get at least assistant, at least showing them this area was changed, we suspect. And there is a lot of big of IBM, you heard about this, robotic medicine, we heard it. So they do try to assist radiologists, not to replace, but to assist. It's a very interdisciplinary collaboration. We need physicists, physician, computer science, biologists, neuro-oncologists. So really it's something that is never standalone. It's always together. And there is a huge shift towards quantitative MRI, meaning we do want to get values, not just relative value. I want to be able to characterize a person by numbers of values that are meaningful. And then if something is changing, I will know that it was changing. This is part of being able really to improve characterization and diagnosis. And thank you very much. Any question? Okay.
When you showed the vascular imaging, what is the resolution there?
Temporal or spatial?
Spatial.
Depends which method.
Can you?
Yeah, I will do. Okay, put here then. Those are EPI methods. When we talk about DSC, sorry, it's even here. When we're talking about, okay, let's even go. Here we have 0.5 millimeter by 0.5 millimeter by 0.5. It's reconstructed, but the contrast shows you only large blood vessels. When we're talking, this is an EPI, so it's 2 by 2 by 5. This method we can improve. It's always just a question, when we play with high spatial resolution, it's on expense of the temporal resolution and vice versa. So it's always a play trade-off. This is not big vessels. The DSC and DC, you really see perfusion. You can go to 1 millimeter by 1 millimeter by 3, and you can see cortex and you see nuclei. Usually, if you are looking for tumor, it's big. So it depends what, when you look for specific, so it's always, like I said, you tailor also what's important for you, temporal or spatial. ASL is also EPI. They're trying to push the temporal resolution. Theoretically, can be excellent, even 5 milliseconds. It can be very, very fast. Depends how you build. Again, an expense of spatial or longer scan duration. Okay.
Thank you very much.
Thank you.